Good morning. Welcome to this session. We will talk about economic and health impact of diabetes and cancer in Africa. It's a great pleasure for me to take part again to this great conference of AfHEA, since the third one in Accra in 2009. It will be a bilingual session, and we will have 4 speakers in 5. And one speaker will talk in French. And to manage this session, we are 2. I will be with Mr. Doua Ruffin, who is economist consultant in Félix Houphouët-Boigny University in Côte d'Ivoire, also a PhD candidate in health economics, working in health insurance development also. And I am Nomtondo Amina Wedraogo Zungrana. I'm a physician, a senior lecturer in dermatology in University Joseph Kizerbo in Burkina Faso, and also a health economist. And I was the past president of Burkina Faso Health Economists Association. So we will start with the second speaker. The first one is not ready. And should we talk about treatment costs for patients with colon cancer and at Groote Schuur Hospital in South Africa? So Mrs. Kelechi Amarachi Neme, master candidate at University of Cape Town in South Africa, who will make this presentation. So let's welcome Mr. Kelechi on your applause. You have the floor.
Good morning. As rightly introduced, I'm Kelechi Nene. I'm a clinical pharmacist by profession, and I have just recently submitted my health economics dissertation. And I'm excited to share with you this morning some part of the work I have just completed as part of that dissertation. The title of the work was to estimate the treatment cost of colon cancer at a tertiary hospital in the Western Cape of South Africa, known as Groote Schuur Hospital. So as a background, why have I taken up this study? Colon cancer, just like every other cancer, is a driver of morbidity, mortality, and costs, both financial and economic. Africa particularly faces a really high mortality to incidence ratio of cancer. South Africa in particular has the highest global mortality to incidence ratio for colon cancer. So if we can just take a look at the graph over there, you can see other continents and you can see the incidence of colon cancer with less mortality rates. And now you can see the yellow lines that represent the mortality to incidence ratio. This gives us an idea of how fatal this cancer is, even though the incidence is considered relatively low. So therefore, there is need for public health measures to improve these outcomes, but with the absence or lack of cost data, planning can't be possible. Therefore, we attempted to estimate the stage-specific cost for treating colon cancer at a public tertiary level health facility in South Africa from the healthcare provider's perspective. This perspective is really necessary in South Africa, given that there is a high level of government financial funding for healthcare, particularly for cancer. So most of the financial burden for treatment of most cancers in South Africa is borne by the government. So we attempted to estimate the treatment components and link them to relevant cost inputs. And then we also went on to estimate a guideline-based per patient direct treatment cost And then we went on to identify the specific treatment cost drivers for this facility. So as an introduction to my methods, for the design, this was purely an ingredient-based and expert-informed guideline cost estimation. This happened at the colorectal clinic and the combined oncology units, both at Groote Hospital in South Africa. For us to come about costing, we followed twofold method. For the first process, we spoke to experts, we spoke to oncologists, we spoke to colorectal surgeons, we spoke to chemotherapy nurses, and we spoke to a number of pharmacy staff as well as other admin officers to find out what are the really necessary resource inputs that go into providing the treatment for colon cancer. And then we created a structured model in Excel and used the bottom-up valuation method to estimate this treatment cost. And then we did a little scenario analysis. So for the capital cost, we considered the building, the cost of the building space, we considered the cost of the equipment and furniture. And we presented this cost using an annualized replacement cost per treatment duration. For the annuity function, we used a 3% discount rate. We used an expected lifetime years as provided by the experts when we spoke to them. And then we also got our replacement cost either from Groote or independent suppliers. So for the recurrent cost, we considered the personnel time cost. We considered the pharmaceuticals, where you have the medications and the necessary medical equipment, consumables. And we also considered and made use of some facility service charge, particularly for the diagnostics, because we couldn't go down to build up cost for that. So just to present my results, we found out that there were basically 3 major components of colon cancer treatment in this facility. The first was consultations, followed by surgery and chemotherapy. The consultations were further broken down into the consultations before surgery and the consultations after surgery, presented as pre-operative and post-operative consultations. And we also considered the multidisciplinary team meetings that feed directly into these consultations with regards to the treatment of the patients. So we also estimated the cost for surgery. From our discussion with experts, we found out that for really early stage patients, they could opt to have a single-sided laparoscopic colectomy, but for advanced patients, they would need an open procedure. And even for the stage 4 patients, they would go on to need a liver resection. Following the surgery, another important aspect that we included in the cost was the post-surgical inpatient admission following surgery. And then we also considered the cost for chemotherapy. These are the 2 main chemotherapy lines provided in this public facility, so we also provided their costs. So here is our total cost. You can really appreciate what is going on even without me speaking much. There is an obvious stage progressive cost escalation. You can see what is happening, even though the cost is high as well, ranging from about 3,000 USD to 9,000 USD. You can see that cost literally escalates as disease escalates. This is a guideline-based cost. Some might argue and say this is not empirical, this is not real world. But if this is what happens with what is in the guideline, then it definitely informs what happens real world. So we look at the treatment cost drivers. Right here you can see for surgery, the yellow bars, that was the most cost-intensive component across the 4 stages of colon cancer. And then we could also see that the inpatient stay after surgery, the green bars, also contributed quite significantly to increasing the treatment cost. We found out that at the facility, because surgery is the, will I say, the backbone of treatment for for such soft tissue cancers, that the cost for surgery and the need to stay in hospital after surgery contributed the most cost of the treatment. So for our scenario analysis, we thought about two scenarios. In the first scenario, we assumed that we did an alternative staffing. So the idea behind this was, instead of using the grade level nurses that we found out that would do most of the tasks, we used lower grade nurses. And we tried to know, does this have any effect on the actual cost? The idea of this is that with the public health sector in South Africa, there happens to be a lot of tax shifting. So sometimes, even though you know a specialized nursing officer should be doing this, there might not be that sister on the ground, and just another graduate nurse or, trainee nurse could even come in and do that. So we had to assume that situation and check if we use this lower staff, will it affect the cost? We also assumed another scenario where we reduced the inpatient days after surgery by 25%. This particular scenario was, we decided to adopt this scenario because there has been a study in this specific facility to show that protocols that reduce the patient's stay in hospital after surgery have a tendency to improve life and even cost. So we adopted that to check if that effect would be visible in our results. And as you can see, the cost for treatment when there is a 25% reduction in post-operative inpatient days. So we can see, I need assistance, please. The cost for treatment when there is that reduction in days was literally smaller than the base case cost, which we estimated. Thank you. Thank you. Okay, and also the cost for alternating staff was also smaller, even though the difference is not much with that, but we saw an appreciable 5% decrease in cost across all cancer stages by just reducing the inpatient stay by 25%. So as a conclusion and policy implications, we can conclude that there is a significant per patient cost burden. This information is very necessary for planning, treatment planning in the facility, and even in the Western Cape of South Africa. We find out that although it seems this is the cost borne by the healthcare facility, how does it influence policy? It's not patient cost. We also remember that most of this cost is borne by the public. There are other things that this money would rather be used for. So when we provide this evidence to them, they would better be informed to know how to manage the resources on hand to treat the number of colon cancer patients they have. We also see that stage-specific treatment cost increases with advancing cancer stage. This is the heart of my research. There is need for us to advocate for early cancer diagnosis, particularly in countries like South Africa, where we believe there has been an advancement with treatment. We shouldn't focus much on treating, because most times when these patients come in late, not only do we spend way more on treating, as we can see from my results, most times we still lose them. So there is need for us to emphasize the point that if we can implement screening programs, if we can implement routine checks, there would be a really great drop in the need for us as a government to invest in treating patients that present late with cancer. We also see that surgery and inpatient stay after surgery were the major cost drivers. This calls for us to enhance or look for more efficient surgical procedures. Although using the laparoscopic procedure is efficient, it is quite cost-intensive. It's efficient on the part of letting the patients recover quicker than having an open procedure, but it requires some quite advanced machines. So we must actually look into how to increase the cost effectiveness of these procedures and know if it is really worth it. Also, we see from the scenario analysis that the reduction in the number of inpatient days after surgery may reduce per patient treatment costs. There are protocols in the Western world already established. An example of one is the enhanced recovery after surgery. These protocols are key. If you implement them, then even after open surgeries, patients are able to leave the facility in as little as 48 hours. So there is need for us to inform the facility and the government to look into establishing these protocols. If we can reduce the length of stay in hospital, we won't only reduce the cost, we would also improve the quality of life of the patients. So thank you very much. I would like to acknowledge my supervisors for their guidance and support, Professor John Atagoba, Dr. Lucy Kunama, and Professor Jennifer Moodley. I would also like to acknowledge the African Awareness of Cancer and Early Diagnosis, a research team where I am currently a scholar. I also want to acknowledge the Health Economics Unit and AfHEA for sponsorship to attend this conference. Thank you very much.
Thank you very much for your relevant presentation. So we can note that for significant, the cost can be significant per patient, and the stage-specific treatment of course increase with advancing cancer and reducing in number of inpatient days after surgery may reduce per patient the treatment of cost, the cost of treatment. So I suggest we can keep the question for the end of the session after all the presentation. Now we will move to the second presentation. We will talk about, I will continue in French. Nous allons maintenant parler des dépenses catastrophiques de santé et leur impact sur l'appauvrissement et l'utilisation des services de santé au Sénégal de 2014 à 2019. Et pour cette présentation, nous recevons Madame Tia Nguyen, qui est la coordonnatrice de la cellule d'économie de la santé du ministère de la Santé et de l'Action sociale du Sénégal. Nous recevons Madame Nguyen sous vos acclamations.
Merci beaucoup, Madame la modératrice. Bonjour à toutes et à tous. Donc, j'ai l'honneur et le plaisir de partager les résultats de l'étude sur les dépenses catastrophiques en santé au Sénégal. Donc, après une étude qui a été déjà faite en 2011, donc nous avons voulu renouveler ça avec l'équipe de la cellule d'économie de la santé, avec l'appui de l'Agence nationale de la statistique et de la démographie du Sénégal. Donc, la période visée, c'était la période 2014, 2018, 2019. Comme vous le savez, ces résultats dépendent de l'enquête harmonisée des ménages. Donc, si on n'a pas une enquête sur la pauvreté ou bien sur les ménages, nous ne pouvons pas, avec les résultats des comptes, simplement faire cette étude. Donc, nous allons suivre ce plan pour pouvoir partager ces résultats. Nous allons d'abord parler du contexte de l'étude, de la méthodologie utilisée, des résultats et enfin de la conclusion. Quel est le contexte donc de l'étude? Comme vous le savez, en 2017, le rapport des Nations Unies sur les ODD de 2020 indique que seuls 12 à 27% des habitants des pays à faible revenu étaient entièrement couverts contre le risque sanitaire. Donc, si on place le contexte en Afrique subsaharienne, les études empiriques menées sur les dépenses catastrophiques de santé ont révélé que leur incidence était de 8,66%, au seuil de 40% au Burkina Faso en 2006 et de 2,4% au seuil de 10% en Côte d'Ivoire en 2015. Donc, ce qui on peut collaborer avec les résultats du Sénégal, qui était à de 2,59% des ménages sénégalais qui faisaient face à des dépenses catastrophiques au seuil de 40% et que 1,78% était approuvé du fait des paiements directs durant la période 2014-2016. Donc, la contribution des ménages du Sénégal dans les dépenses totales en santé est élevée. Donc, sur la base des résultats des comptes 2013, 2014, 2015, 2016, nous avons vu que les paiements directs diminuent d'une année à une autre. Il est passé de 55,1% en 2013 à 48,8%. Donc, alors que le pays s'est engagé à aller vers la couverture sanitaire universelle et aussi à avancer, atteindre les objectifs de développement dont le troisième consacré à la santé et au bien-être. Aujourd'hui, si on veut vraiment évaluer les ODD, il faut qu'on ait les résultats sur les dépenses catastrophiques de santé et les résultats sur les comptes de la santé. Comme une petite définition par rapport à la méthodologie, qu'est-ce qu'on entend par dépenses catastrophiques de santé? Selon la méthodologie de l'OMS, un ménage fait face aux dépenses catastrophiques si ses dépenses totales en santé sont supérieures ou égales à 40% de sa capacité à payer. Et la capacité à payer est calculée sur la base des dépenses totales et des dépenses en alimentation, donc au seuil donc de cette ménage-là. Donc, les résultats ont montré ici que plus on est pauvre, plus on a un taux qui est très élevé par rapport à l'utilisation des services et aux besoins. Nous avons aussi constaté que par rapport au quintile numéro 1, qui est le quintile de pauvreté, et le quintile numéro 5, qui est un quintile là où on a les personnes qui sont dans le bien-être, que les services, plus qu'on est au niveau par rapport à l'utilisation, ici on est à 1,7%, alors que par rapport au quintile numéro 5, on a vu que le bien-être a un impact sur l'accès donc à l'utilisation des services. Nous avons compris aussi par rapport aux résultats que le niveau d'instruction impacte donc sur la fréquentation des services. Plus on est instruit, plus on fréquente plus donc les services de santé. Donc, raison pour laquelle vous avez vu ici dans les résultats, celui qui n'a pas une instruction, qui n'est pas du tout instruit, il est à 60,7% comparé à celui qui est au niveau universitaire, qui est à 69,6%. Toujours par rapport aux résultats, nous avons ici la part des paiements directs de santé en pourcentage de la capacité à payer qui passe de 6,2% à 5,3%, puisque ce sont les 2 années que nous avons étudiées, 2014, 2018 et 2018. Donc, raison pour laquelle, toujours, on vous donne les résultats par rapport à ces périodes-là. Au seuil de 40% qui est indiqué par l'OMS. L'OMS nous demande de calculer le seuil à 40%, mais pour nous permettre de nous comparer avec d'autres méthodologies utilisées par les ODD ou bien par la Banque mondiale ou bien par d'autres institutions, que nous avons calculé les seuils de 40% pour l'OMS pour nous comparer avec la première étude que nous avons réalisée en 2011 et le seuil aussi à partir de 25% et de 10%. Et les résultats nous permettent vraiment de nous comparer entre pays. Et au seuil de 40%, nous avons un résultat de 1,4% et 1,1%. Donc 1,4% en 2014, 1,1% en 2018-2019. Donc des ménages ont respectivement fait face à des dépenses catastrophiques, ce qui est vraiment un résultat qu'il faut vraiment analyser donc dans le cadre de l'atteinte de la couverture sanitaire universelle. Est-ce que nous devons avoir ce résultat-là, donc dans ce contexte-là, qui est un contexte très particulier et que tous les pays veulent vraiment aller vers la couverture sanitaire universelle par rapport aux deux ces suivants. Ça, c'est pour des besoins de comparaison que nous avons calculés. Donc, c'est aussi de 25% et de 10%. Donc, ces résultats sont ainsi libellés dans ce graphique-là pour montrer l'évolution entre les 2 années, donc l'année 2014 et la fourchette 2018-2019. Ici, nous voulons montrer l'impact des paiements directs sur la pauvreté. Donc, plus qu'on est au niveau rural, plus qu'on est vraiment pauvre. Parce que déjà, le taux de pauvreté avant paiement direct, donc comparé au taux de paiement de pauvreté après paiement direct, nous avons vu qu'il y a une évolution. Donc, avant paiement direct, pour ceux qui habitent au niveau urbain, ils sont à 5,2%, mais après paiement direct, nous sentons une évolution. Donc, d'où l'importance aujourd'hui d'agir sur les paiements directs. Parce que les paiements directs impactent sur les dépenses catastrophiques. En conclusion, nous pouvons dire que les ménages les plus pauvres sont plus susceptibles à faire face à des dépenses catastrophiques de santé, surtout ceux qui résident en milieu rural, ceux dont le niveau d'instruction est très faible et ceux présentant un handicap. Donc, d'où l'importance aujourd'hui d'agir sur ces types de ménages-là qui sont vraiment les plus susceptibles à faire face à des dépenses catastrophiques. Nous devons aussi travailler sur les politiques. Nous devons proposer des réformes donc pour vraiment une plus grande prise en charge des dépenses en médicaments, parce que nous avons constaté lors de l'étude que dans la structure des dépenses des paiements directs, que ce sont les médicaments qui tirent. Donc, nous devons vraiment avoir des politiques donc pour les médicaments. Nous devons aussi faire un meilleur ciblage des bénéficiaires de l'assurance sociale. Là-bas, dans les résultats, nous avons constaté que ceux qui ont un handicap ou bien ceux qui sont plus pauvres sont susceptibles vraiment de faire face à des dépenses catastrophiques. Donc, nous devons faire tout pour avoir une politique sociale d'encadrement de ces groupes vulnérables. Et je pense que le Sénégal est dans cette politique de couverture maladie universelle et d'autonomisation aussi des groupes vulnérables pour permettre donc d'éviter ces dépenses catastrophiques. Comme autre proposition de réforme, nous devons bien définir les paquets de services gratuits concordant à leurs besoins spécifiques. Il ne s'agit pas de dire que nous avons identifié des paquets simplement sans pour autant réfléchir sur la pérennité. Parce que déjà avec l'avènement de la couverture maladie universelle au Sénégal, plusieurs structures hospitalières sont à genoux. Parce que déjà, il y a un problème de financement et de remboursement des prestations, des paquets qui étaient définis par groupe, par type de gratuité. Mais actuellement, nous sommes en train de réfléchir sur des réformes pour rendre l'assurance maladie obligatoire de façon intelligente. Parce que la gratuité ne peut pas nous permettre vraiment d'aller vers la couverture sanitaire universelle et que toujours, gratuité, il y a toujours quelqu'un qui paie. Donc, l'État paie et l'État aussi ne peut pas assurer de façon pérenne donc les remboursements donc, par rapport à cette gratuité. Nous devons aussi, enfin, améliorer les politiques pour réduire les paiements directs de santé qui sont des sources de dépenses catastrophiques. On ne peut pas dire que d'emblée, nous devons abolir. On ne peut pas abolir les paiements directs, mais quand même, nous devons réfléchir pour voir comment diminuer ces paiements directs. Actuellement, avec les derniers comptes du Sénégal de 2022 à 2022-2023, nous sommes presque à 48%, bien qu'en 2013, on était à 55%. Nous avons senti une diminution des paiements directs, mais ça ne suffit pas. Parce que selon l'OMS, les paiements directs doivent être autour de 20%. Donc, nous devons vraiment faire tout pour que ces politiques-là puissent nous permettre de réduire donc drastiquement les paiements directs pour l'intérêt des groupes vulnérables. Voilà, mesdames, messieurs, ce que je voulais partager avec vous sur les résultats des dépenses catastrophiques donc effectuées au Sénégal. Merci beaucoup.
Merci encore, Madame Gay, pour votre communication très intéressante. Ainsi, nous retenons qu'au Sénégal, 2,59% des ménages font face à des dépenses catastrophiques de santé et 1,78% se sont appauvris par le paiement direct, surtout ceux qui sont en milieu rural et ceux qui ont un niveau d'instruction très faible. D'où la nécessité d'un meilleur ciblage des indigents par l'assurance maladie afin de réduire les paiements directs. Merci encore. So let's move to the third speaker. We talk about the burden of Type 2 diabetes on the productivity and economy in sub-Saharan Africa, a life table modeling analysis from South Africa perspective. And the speaker is Dr. Helebo Asejid from University of Cape Town. So let's welcome Dr. Helebo on your applause.
Good morning, everyone. So the topic says Sub-Saharan Africa because this is the first of its kind when non-communicable disease such as diabetes, which is quite high in African continent, is being quantified in such a model. Sorry, are you operating? Okay, sorry. So the topic says the burden of type 2 diabetes on productivity and economy in sub-Saharan Africa. It's a life table modeling analysis from South African perspective. So I'll be using South African data to take us through this. The study has been published. It's part of, okay. The study has been published and it is part of my PhD exercise. And you can find the article. And the second article that you see on the right is the commentary from one of the 3 supervisors that I had as my PhD journey. And the structure of the presentation is as you see it above. Defining diabetes. Diabetes is a chronic disease and it is a metabolic disease that causes high blood sugar. It's one of the fast growing diseases globally and in the African continent quite vast and high. And it has several issues that it causes in our system that uses glucose for energy. And it has 4 types, and we will focus on type 2 diabetes today because it contains about 90% of all types of diabetes because it's a lifestyle-based as well as a dietary and exercise-related impact because of its long-term impact. It is difficult to reverse compared to other 3 diabetes. So giving you some statistics, in 2023, it was responsible for about 6.7 million days, which means 1 death every 5 seconds. And it is one of the major public health challenges, and 1 in 2 people with diabetes are undiagnosed globally, which sits at 54%. As you can see on the far right, diabetes complications are several, from your brain to kidney to all the way to your foot. And it has high financial implication because once you're diagnosed or once you have it, it is for lifetime. And it comes with several complications, and those are the complications that actually cause the death or the financial burden. Moving along. So to provide you some global diabetes prevalence, as you can see, the world has average of 51% increase expected by 2045. And if you look at other Western Pacific, for instance, you look at Europe, up here 15%, but over there, look at Africa. 2045, the expectation is to increase by, it's estimated that it's going to increase by 143%. This is according to International Diabetes Federation. And it has so many impacts. 3 in 5 people with diabetes are undiagnosed, and 3 in 4 deaths due to diabetes were in people under the age of 60. So keep that in mind, that under age 60 means that you are more or most productive, and this model is going to focus in that aspect. So we will talk about it as we get there. I'm not going to take us through all of this background, but to give you some context in South Africa, because of the epidemiological transition, which all African countries are going through, diabetes and other lifestyle transitions, is quite high. And as you can see, 69% of women, 39% of men, overweight or obese in South Africa, and the outcomes are quite worsening, given the lifestyle, alcohol, tobacco, and so forth. And diabetes in the working population has more than doubled in a decade, where our study is using data from 2019. That's why I used 10 years prior to the data we used, because COVID hit in 2020, so we didn't want to dilute the outcomes in the data, because there was a relation between COVID and diabetes. We didn't want to have many limitations. Therefore, we used data from 2019, and I'll get there. So if you look at undiagnosed in South Africa, it's 85%. That's the estimated number. Therefore, it makes it even the estimation that we have is even little, because if more people appear to or to find out that they have diabetes and we have to incorporate that, then the outcomes will be quite devastating. And data trends are showing that it's impacting rural, urban, women and men. So it's not only in one area. Looking at the economic burden. Yeah. So it is the second leading cause of disease in South Africa after TB, and it requires 2 to 3 times more healthcare resources. The studies have been done on that area, and the increase, as you can see, in 2023, 4.6 million individuals were estimated to have been living with diabetes, and that number is expected to rise to 7.5 million by 2040. And a financial direct study conducted in 2017 says that every year the South African public health sector, without including people who are in private insurance, which a lot of people are in, spending about 150 million. And if we include undiagnosed ones, the expenditure is estimated to rise to 1.2 billion. And I want you to keep this point in mind, which is the intangible cost, because these are direct costs that have been estimated. And often the intangible cost, indirect cost, it resides under the limitation section of every publication you see. That is what we try to look at. And so that's when the indirect cost or the intangible cost, which, sorry, could you load it again, comes into effect, where because of diabetes now, you are not fully functional or you are absent at work. So there's absenteeism, presenteeism, and there is excess death, because if diabetes was not there or diabetes did not cause a complication, you would have been fully functional and you'd have been 100% healthy person, assuming that you don't have other diseases. So because we want to model the diabetes impact only. So looking at, in economic evaluations, we often quantify cost minimization, cost effectiveness, cost benefit, right? We have DALIs and QALYs to show life saved or days averted, but we often don't assess the economic cost, which is productivity adjusted years of life. Then if you look at the definition or a bit of explanation from the commentary, it's not intended to replace any QALY or DALI. It's just that it's to quantify population level impact of diabetes. Therefore, we're going to see impact of a disease arising from unemployment, days off work, which is absenteeism, reduced efficiency, which is presenteeism, and earlier death. For instance, if a country has life expectancy of 78 years, and because of diabetes, you die quite early, which means the economy has lost out. So that's what we're going to quantify as well, and I will take us through there. So let's say there is a hypothesis behind it, which is, let's say you are healthy. So the model description for cohort with type 2 diabetes hypothesized you are healthy, and then time comes, you die. And here is another description. You are healthy, you live with diabetes, then that's where you incur all the financial costs as well as the productivity loss, which causes several other causes impacts to GDP, which I'm going to take us through just now, and you die. So our focus will be here, alive with diabetes. That's where we're going to focus. So to just explain what happens when we say productivity is that there is a productivity index, which is based on absenteeism and presenteeism. That means that if you, for instance, looking at the figure 3, where cumulative PALIs over time is, you look at the red line, it shows that you have diabetes, your time horizon is shortened. But assuming that you don't have your lifespan without condition, as you can see. So here, there is financial as well as economic burden, and we will look at the economic burden here in this study. So the objectives, as I've been alluding the whole time, is that we want to find out what is the excess mortality and what is the years lost. Years lost in a sense that you're supposed to live until 78, you died earlier, which means there are years that lost. And what is the extent of productivity adjusted years of life lost in a working population in South Africa, which is 20 to 65. And we're going to look at that. So looking at the model or the methods, how we did that, we created a static life table, model with a single year cycle, which is 2019, to extrapolate and find out what is the lifetime impact of a disease. So then the simulation was constructed as with a cohort of people living with diabetes. Say, let's assume there's no diabetes, and we take that the number and we resimulate and say, let's assume there's no diabetes. So there are there's a cohort where we are living with diabetes. Then we hypothesize that they did not have diabetes using some of these data sets. I won't take us through all of this, but all of these data came from either the bigger macro level or IDF, International Diabetes Federation, World Bank, or we extrapolated some of the data because it's not easy to collect intangible aspect of these directly from patients. So quickly, so the productivity burden, which is characterized by, two things, which is labor force shortfall. You die and you exit labor force earlier than anticipated, which is 65 years old in South Africa, and productivity index. Productivity index is absenteeism and presenteeism caused by diabetes-related impairment. And to create the matrix for PALIs, what we did is productivity index multiplied by each year lived in a labor force with diabetes, or that cohort with diabetes. So that has its own calculation, which I try to simplify it here from the formulas. And most of the information is used from, global burden diseases studies, Africa, American Diabetes Association estimations, and the existing literature that was published, I think, from Asia Pacific, because we have genetical relation with population in Asia Pacific, given that we don't have studies to use. So I had to somehow extrapolate using different tools. Therefore, we, excess death and years of life lost and PALIs. That's our goal. So the data analysis, so the relative reduction applied into 1 year, and we stratified it into each 5-year gap group, because death amongst population with age 20 to 25 is not the same as those at 55 or 60 something, because they already, you know, their time span is already in a downward sloping. So we created 5-year cohort so that we report our results within those 5 years, so that we don't have to, you know, dilute some of the people that are already old and have different comorbidities to the young ones who are 20 years. So the model that we used is human capital approach. It is used in economic valuation to estimate impact of a disease, such as diabetes, using GDP per capita, effective full-time employee. Keeping that in mind that we're not taking part-time and other things, which I will speak when I'm speaking about the limitations. And we looked at utility scores, utility score, of course, to see health-related quality of life. That feeds into quality adjusted years of life, then feeds into productivity adjusted years of life. And the assumption is 1 productivity adjusted years of life equal to 1 GDP per capita. That is, there's evidence exists and they equate these two, and this is the assumption we're using. We did run sensitivity analysis and we assessed the impact of uncertainty by varying some key parameters, one at a time. Let's look at the results. So the younger group, which is age 20 here to 34, the excess day relatively low, as you can see, because this, which means either they just contracted diabetes, they still have to build comorbidities and other things for them to weaken their system, or because of we are working from a cohort of 20 to 65, also there are other factors. But the proportion or the percentage of years of life lost is big in that cohort because they are expected to live longer and remain in the workforce for about 40 years. So if we lose 1 or 2 within this cohort, means higher impact in percentage of years of life lost compared to this group. Looking at the middle age, 35 to 49, so excess mortalities increase significantly for both genders, and particularly if you look at 40 to 49, and 45 to 49 is the highest for women. So middle age is the age that has higher impact. So looking at the older group, so although the absolute number, you know, here, this is women, this is men, remains high, but you know, percentage of years of life, it's not much because their time span is already matured. Therefore, it decreases because the cohort has lower remaining life expectancy. But at the end of the day, to conclude what excess death was caused by diabetes, women had the greatest number, which means that we lost more women compared to men in like 353,000 versus 315. However, men had more total deaths. This is because there are factors in this. The risk of death is more sharp in women relative to men, because what we saw from the model is that more men, the expectation in the mortality rate is that men die at earlier age than women. I guess because we're always involved in a risky behavior of some sort. Also, there is an aspect of health seeking. We don't finish our medications and so forth. The life expectancy of men is shorter than women without adding diabetes into the equation. So that factor explains, regardless of this number is high, if you look at the proportion of men that are in the workforce pool and you look at these percent, it's high. So looking at the years of life lost. So here the purple is men or green, and the reddish color is for women. As you can see, the middle age between 35 to 49, for both genders, has higher impact. This is because complication of diabetes, kidney failure, heart disease, heart stroke, and so forth, they tend to be worsened between the age of 35 and 49. Therefore, both something similar in both genders is that middle age is the age that we lose a lot of years of life that are productive. So on average, if you look at the green trend line, which is the percentage, men lost 11.7%, and women 7.7%. This suggests that men might, experience more severe complications or have poorer management compared to women. That goes back to health-seeking behavior and other aspects. When complications creep in, women seem to follow what the doctor is saying, and they take the medications, and men seem to fall off on that. That's why we lose more men than women. So, in the last point is that years of life lost decreases at the age of 55. So if you look at this and this bar, it's due to the other effects. And this population at this age, they already have few years left in the working environment, because the model is the expectation is that they retire at 65. So the years are already low. The third result aspect is percentage of PALIs, which is productivity adjusted years of life, and per person PALIs lost. So if you look at the trend here, the red one. So as you can see here, this is for men and this is for women. For women, it starts quite high. The productivity adjusted years of life lost, because of women stay longer in the work labor pool, facing several disabilities and productivity adjusted years of life in the working pool, but men exit because they die earlier. Therefore, we lose productivity from men because of excess death, while we lose more productivity from women from existing in the pool, but being less productive and absent at work, or just staying at home and just quitting the work, but not dead. So this I just explained. So on average, men lost 22.5% of their productivity adjusted PALIs, while women lost 37. That explains the qualitative aspect of the explanation I just provided, because men exit earlier. So when we look at per person PALIs lost, on average, men lose 2.6 life years, while women lose 3.6 life years. Although this aligns with the fact that women tend to live longer than men, meaning they have more years available to lose in disability and productivity adjusted life of years lost. The economic aspect, the key aspect that we wanted to see, because what we're trying to do is that we are linking what we normally say, health is wealth. If you are healthy, you are staying, you are working, you are producing money to the government through the tax or other aspects. But you leave earlier. Either you're alive and you're not productive, or you're dead. So earlier on, I did mention that the assumption is 1 PAL is equal to 1 GDP per capita, and we are using human capital approach. So from the model, we found that throughout their lifetime, people who are living with diabetes lost 13.5 million PALIs because of type 2 diabetes, which translates into economic output or economic burden. And as you can see, 8.7 million is lost from women and 4.4 from men, because men leave the pool early, so there is less PALIs lost compared to women who stay longer and face a lot of disability. So according to the health human capital approach, which is a concept based on, people are economic assets, and is used to measure value of a person's productive capacity over lifetime, which coincides with what we're trying to do in this modeling. So if we multiply that using per capita effective full-time employee from using South Africa's figures, which is 6.6 thousand in 2019, we find out that total productivity loss in the GDP is $223 billion over working lifetime, which is 20 to 65. And if we look at per person, $69,000 over working lifetime. So we looked at cost drivers. As I mentioned earlier, workforce dropout and mortality, which is earlier mortality, is the other drivers, which is 47 and 37%. Absenteeism and presenteeism is 16%. So if you look at this graph here, you can see this is a graph of mortality. Men, as you can see, the economic burden from mortality is 35.6, while women, it accounts 25.3. That explains the qualitative aspect I mentioned earlier on. So, and when we look at the gender differences, women have higher rates of dropout, which means they are alive, absenteeism and presenteeism, they drop out, that's where the pallies come, and men, of course, exit because they die. Sensitivity analysis, we looked at, by controlling all others, varied one by one, was deterministic sensitivity analysis. And we found these are the 2 points that we wanted to emphasize, which is as your economy grows, because 1.8% was what South Africa's economy was growing in 2019. For instance, let's say economy doubles and grows, which means that the $69,000 per person that we found out can actually go up to 85, which means that you are working to grow your economy, then the burden is also growing. So as you grow that, you should look at that. And population mortality risk. As your population mortality risk lowers, which then you lower the impact on the economy. What's the reflection on this? Is that if you spend 10% of what you're actually losing from the economy, which is $223 billion, then you can actually reduce the cost by about 22,000, or the loss from the economy. That means that you are cost saving. So which means that you reduce $22,000 from the 69. As you invest more in preventative, for instance, you reach around 30 to 31%, you actually deplete that aspect that the economy was losing. Therefore, preventative aspects are the ones, investing in preventative aspects are the ones that are going to fix this. So we had limitations, as you can see, but if you have questions, I'll address these limitations. Can I get a few seconds? Few seconds, no? No, okay. Okay, so yeah, and in conclusion, we need to target, middle age, 30 to 50, because that's where we are incurring so much loss, and we need to have targeted diabetes prevention management strategies to alleviate this. Thank you.
Thank you very much. We start late, so we have to go quickly. So let's go to the last presentation to talk about assessing the driver of non-communicable diseases prevention activities in primary healthcare facilities in Ghana, a case study of some selected districts. The speaker is Michelle Adurayi Amina from Ghana College of Physicians and Surgeons in Accra. So let's welcome Amina on your applause. Thank you.
Thank you very much. Okay, thank you very much. So as you notice, most of our presenters talked about NCDs, but one of the key things they mentioned was prevention. So today my presentation is on preventive activities. But these preventive activities, we are looking at them on the primary healthcare system. Okay, great. Yeah, so over time, we've realized that the primary healthcare system has been effective in reducing comorbidities, mortalities of different illness, okay? And it's been effective in Ghana too. But however, this is the structure of Ghana's primary healthcare system. We start from the community level through to the district level. So we have something we call chips. So chips are like compounds that, okay. Yeah, so chips are like compounds that are designed for communities, okay? You move on to the health centers and then to the district hospitals. But originally, the primary healthcare system was designed for prevention, okay? But you realize that when it came in the initial phases, it was for prevention of communicable diseases, infectious diseases. But we've not really had a lot of literature that talks about how the primary healthcare system has actually been used for prevention of NCDs. And we are all aware that there's actually a burden of NCDs nowadays. So this study basically is to fill that gap, to understand what is our primary healthcare system currently doing when it comes to preventive activities for NCDs. So we are looking at hypertension, diabetes, and what? Mental health. So these are the three objectives. How the primary healthcare facilities are actually engaging in these preventive activities. We are looking at how facility levels and district level factors are actually affecting the ability of the primary healthcare facility to engage in these activities. And also to look at, okay, if they engage in these activities, is it really having an impact on their outpatient department attendance? So do people really come? Okay. To achieve that, this is a method. For our sampling, what we did was we had 3 stages. The first stage was regional selection. So we purposely selected 2 regions in Ghana, which is our Greater Accra region and our Eastern region. Then for the second stage, we randomly selected 10 districts within these 2 regions. And for the third and final stage, for all these 10 districts that we selected, we made sure that we selected all the functional primary healthcare facilities within these 10 districts. So in total, we visited about 210 primary healthcare facilities. Okay. So in terms of preventive activities, I've been saying preventive activities. What do I mean? Okay. For our study, we measured it in 4 different categories. So the first one is community daybares. So in Ghana, we can organize a community daybar where all the community members come, and then we discuss and talk to them or educate them about NCD risk factors. The second is home visit. So we actually go to their homes, talk to them about NCD. And also the third is screening test. And then the last one is within the facility. So if you come into the facility, do we counsel you on nutritional benefits? Or eat this, don't do this. So these are the 4 main preventive activities that we're looking at. So for the factors, we're looking at 2 main factors. The first one is what we call the facility factors. So we're looking at the facility type, the managing authority. We're looking at basic infrastructure. In fact, the resources that is available at that level. And we also looked at the workforce capacity. What is the strength that you have at that particular primary healthcare system? Then we also looked at the district level factors. So the district level factors here are what are the population demographics, okay? We looked at what's the educational level within that particular district. We also looked at economic indicators like unemployment rate. Then we looked at the housing and infrastructure and NHIS coverage. So NHIS is our national health insurance. So for our analysis, we had 3 main objectives. The first one was just to try to look at what are they currently doing. So to do that, we use descriptive normal percentages to see if we go to the facility, among the 4, are you doing it? How often are you doing it? Okay. Then for the second objective, we're looking at the factors that actually influences a primary healthcare facility engaging in any of these four. So to do that, we use the logistic regression. And then the last objective, which was we're trying to look at, okay, if you are actually engaging in these preventive activities, does it cause a change in your OPD? Okay. To do that, we used initially, we are supposed to use the binomial model, okay? But the issue with the binomial model is that when you look at our primary healthcare system, in fact, when you look at the data, our OPD cases recorded a lot of zeros. So because they recorded a lot of zeros, one of the assumptions of the model is that the occurrence of your OPD is over-dispersed, but it's random. But the zeros that we are recording is not random, it's systemic. Because when you go to the primary care system, at the lowest level, the chips, they are not allowed to engage in anything NCD. So because of that, you are likely to see zeros. So when you look at the data, about 50% of them recorded zeros. So in modeling, we needed to account for that. So we use a zero inflated negative binomial model. So these are the results that we had. For the type of facilities, majority of them we visited were chips. And these chips, I mean, is general for Ghana. Majority of our facilities are chips, about 60%. So the facilities that we visited, 55% of them were chips, 30% of them were health centers. Then most of them were government, and most of them were found in rural areas. So for the preventive activities, when you look across, you realize that generally, about for nutritional counseling, about 46%, 54% of them engaged in that. For screening, about 59%. Home visits, we had about 63%. For diabetes, we had about 69%. So what it means is most of the facilities we visited actually engaged in community diabetes. Now, we try to decompose it to be able to see, okay, this is just a great picture. When you decompose it to the primary healthcare system, the structure, what type of facility does what? So for our structure, we start from the chips, we move to the health centers, clinics, and district hospitals. You will see that as you are coming down, or as you are going up the structure, the probability or the rate at which a facility actually engages in that reduces. So what it means is, if you are looking at preventive activities, it's at the lowest level that you see them engaging. But the moment you climb up to the primary health care, to the district hospital, the health centers, it reduces. Okay. So for the logistic regression, basically, we estimated our odds ratio, and then we have our p-values there. So our result shows that the chips were more likely to engage in preventive activities, especially for the home visit. Then government were also more likely to engage. But what's interesting is our resources. You can see that for the odds ratio, when it is greater than 1, it means the probability is higher. When it is less than 1, it means the probability is lower. So you can see that we have a lot of less than 1. 0.9, which is statistically significant. 0.97, 0.97. What it means is, for a facility that has more resources, the likelihood of that facility engaging in preventive activity reduces. So if a facility has more resources, then the likelihood what? Reduces. Yeah. So for the district factors, we looked at age. So it looks like an increase in age of the population actually causes a reduction in the likelihood of a facility engaging in any of these 4 preventive activities. And education actually had the reverse. So an increase in education actually led to the facility actually engaging in more preventive activities. And another interesting thing we saw was that when you go to a particular facility, the increase in the the insurance coverage actually causes a reduction in the likelihood of a facility engaging in preventive activities, which was quite interesting. Okay. So this is our ZIP model. Basically, we wanted to see whether it increases an engagement in any of these activities actually causes an increases in your OPD cases or not. So looking at this, you can see that there is actually a higher likelihood. So it means if you engage in any of these preventive activities, the likelihood of you actually increasing your OPD cases is high, which makes sense. Okay. So in discussion, we can see that from what I've said, when you go down the primary healthcare system, especially from the lower level to the up, you realize that the lower level are more likely to engage in preventive activities, which is quite normal because that's how they were designed. They're actually designed to engage more in preventive activities. And it's also because of the type of cadre of staff that we have there. So when you go there, you have a lot of community health nurses, you have a lot of nurses, midwives, but you find doctors there, okay? Now, another thing we realized was that the probability of a facility engaging in preventive activity, when you look at the resources, actually reduces, which to me, I think is quite problematic. Yes, we agree that, because they have more resources, they are going to engage more in curative care. So they are going to attend to more people. But it's problematic because if the primary healthcare system, a CHIPS compound, goes to a district, they do their preventive activities, and per the results, it's effective that when you do the preventive activities, it brings people to the hospital. Now they come to the hospital and you don't have the resources to take care of them. So what happens? You are like, you people have come, but I have to refer you to the higher level, which is the health center. Now, when you look at this data and you decompose it well, the distance from a CHIPS to a health center, it ranges from 5 kilometers to 25. And the constraint, the economic burden around that is very high. So the likelihood of the person actually following up to a higher level facility is low. Okay? And this is very, 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 very problematic. So what it means is the whole effect of our preventive activity is diluted. Okay? So that is one of the key findings that we found. And also, another thing that was striking was the fact that NHIS actually, the increase in NHIS coverage actually caused a reduction in the probability of a facility engaging in preventive activity, which was quite interesting. But then again, when you dig deep and you ask them, it's because they are focusing more on curative care. If this district has a lot of people who have the insurance, when they come, we would like to attend to them. So we focus all our attention on them. And also, because of the way the NHIS system is structured, there is no component, or there's little component that gives incentives to facilities to engage in preventive activities. It's all curative care. So when you come, you have taken care of this number of people, we reimburse you. But there is no serious model that looks at, okay, so you've also done this number of preventive activities, so we are also going to reimburse you. And that is why we have these results. So these are our recommendations. We are recommending that the government should equip the lower level primary healthcare facilities, even though we know that there's a limitation based on what they are supposed to do, but there should be that form of equipment so that they will be able to attend to those who actually follow up based on the preventive care. We're also saying that you should also promote preventive care at higher level primary healthcare facilities. So it's not just the lower level. When you look at it, you realize that for CHIPS, they are located in rural areas. That doesn't mean that the urban areas, there's no NCD. There's hypertension, there's diabetes there. So we should also try and focus our attention on the higher level of the primary healthcare system, where we have innovative ways of conducting this preventive care. Then also we are saying we should enhance outreach to male population and also revise the health insurance coverage. Try and adjust it so that it can incentivize the primary healthcare facilities to engage in that. Yes, so I think this is it. Thank you. So this research is being funded by the NIHR Global Health Research for NCD in West Africa. And these are the partner institutions. So I want to give acknowledgement to them. Thank you very much.
Thank you very much. We will invite our speaker to the panel for a small discussion. We are sorry for the time. We also lose 30 minutes because of plenary session who is not finished. So come to the panel. Have you some question for our speaker? Okay. You have the floor.
Thank you very
Introduce
much.
yourself before, please.
Okay, hi, my name is Chijo Kenwosu, and I am an associate professor at University of the Free State, South Africa. And thank you, colleagues, for your presentation. Sorry, I joined the session very late, so I came in when the colleague that was making the beautiful study about TB disease burden in South Africa. Thank you so much, very interesting. Quickly, I was a bit, maybe because I came in late, can you just explain, clarify, how did you account for unemployment, the high unemployment rate in South Africa? I mean, it's over 30%, right? I will imagine that you only focused the analysis on those working or what? And I saw that you said one pali is equal to 1 GDP per capita. Do you think that with the very high unemployment rate in the country that you are overestimating the pali? Thank you very much.
Thank you. Another question? We will collect all the questions before answer. Okay, I have a question for Madame Gay. Comment est-ce que vous avez identifié, est-ce que votre étude a permis plutôt d'identifier les indigents pour être pris en charge par l'assurance maladie? Et est-ce que vous avez pu déterminer les maladies qui ont fait l'objet de cette dépense catastrophique de santé? Ça pourrait aider dans les politiques de prévention. Thank you. Yes, a question?
Ok, merci. J'avais une question pour Madame Tienne. C'était pour comprendre une notion en fait. Vous avez parlé de taux de pauvreté avant et après paiement direct. Je n'ai pas vraiment compris. C'est juste pour comprendre cette notion-là. Et puis, also for Mrs. Kelechi, on the recurrent cost, you spoke about facility service charge. You speak health workers, pharmaceutical product, and also facility service charge, just to understand what is it. Thank you.
Okay, another question.
Thank you. Mine is to Ghana presenter. So if I look at the recommendation to equip, to enhance, so the issue is, are you recommending that these very lower health facilities move to do prevention activities for NCDs or what? Because I know that normally in the package of activities, even at the district level, the issue of NCDs are not part of it. But now I know that we are working at the regional level to get the NCD aspect to be part of activity to be conducted by at the district level. So that's my question. Yeah, thank you.
Thank you very much.
Voilà, donc je vais poser une question, mais pour le professeur pour l'Afrique du Sud, peut-être si on peut lui... Voilà. Donc, ma question était que les résultats qu'on a vus sont des résultats vraiment qui sont probants, mais je n'ai pas vu de recommandations par rapport à l'étude. On sait que ce sont les jeunes n'ont pas eu de comorbidité. Quelles sont les préventions qu'ils prennent au devant pour pouvoir donc avoir moins de comorbidité par rapport aux jeunes? Merci.
I have a question for South Africa presenter about the recommendation for the younger. Do you have a recommendation for the younger in your study? Another question? Okay, I give you the floor. You can start.
Okay. Gentlemen from UFS, thank you for coming. In terms of unemployment, we did not include unemployed into the model because we do understand that not everyone with diabetes is employed. So we reached out to the vital statistics department at Statistics SA. They provided the data stratified by all types of employment, seasonal, so forth. But we only used effective full-time employment because human capital approach suggests that that is the GDP per capita full-time effective employment that we should incorporate into. Therefore, to your follow-up question that says, does that make sense to say 1 PAL equal to 1 GDP per capita? It, 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 that's the justification. We did not include unemployed, part-time, seasonal. So that's part of my limitations, that we did not include that, and if we incorporate that, it does, the result do go quite higher, and maybe that should be done, and it was part of the limitation. I just didn't have time to articulate that at the end. And for your question on the younger,
I'll just translate the question of.
translate.
Yeah. It's not my question. Go ahead.
Oh, okay. There's another question I did not hear. Sorry. Is that, are we fine with your? Did I get?
Can I
Yeah.
come
Yeah.
about the question?
Okay.
Because in your study, you talk about comorbidity.
Correct.
Yes, so she wants to know if there is any recommendation you can have for this younger with comorbidity.
Okay. So the root cause of the comorbidities is actually the type 2 diabetes that's causing. So the recommendation or the reflection that we had is that if you spend 10% of what you are losing in preventing diabetes, you automatically eliminate the comorbidities such as kidney nephropathy, so some, amputations, some people lose body parts and so forth. And for younger people, maybe the governments spend on preventative measures, advocacy, awareness, so that there's exercising, there's healthy eating. And for those who are living with diabetes also to do, self-care management, because there is a guidelines. I do have a study on that. Unfortunately, I won't be presenting here, but there is also, for those who are living, we also have recommendation on full practicing of, adherence of guidelines, partial and none. And we also worked on the determinants, including mental health and so forth, extensively in that PhD thesis. Yeah, thank you so much.
Thank you. Can you give us in one sentence a take-home message from your study, please?
Okay.
Before passing the.
The first one is that the indirect and intangible cost of diseases should come out of the limitation section, which we always put that limitation first. So we always want to know the financial aspect, but the economic burden of, and especially chronic diseases that we live with for lifetime, are quite high than the financial. The second one is that we should work on preventative measures instead of going to pharmaceuticals to get tablets for people living with diabetes. We should also spend portion of the money to create awareness in young people to cut alcohol and smoking, for instance, because that contributes very immensely.
Thank you very much. Let's move to the second speaker.
Thank you for your question. So what I mean by facility service charge, there were some components of treatment that we could not walk up their cost. For example, would be the diagnosis, the lab tests that are run before surgery and all that, and also the inpatient admissions. Given the scope of the study, We just used the facility service charge for such components of treatment.
Excuse, so it's not the, comment je vais expliquer ça? En fait, ce que je veux comprendre, parce que je pensais que c'était quand elle dit le service, puisqu'il y a déjà les éléments à l'intérieur. Puisque à l'intérieur, en fait, il y a les éléments. Je sais pas, j'ai pas compris exactement ce qu'elle elle dit. Puisqu'il y a le personnel de santé et il y a les produits pharmaceutiques. Donc, elle dit en plus de ça qu'il y a d'autres, c'est des services. Mais c'est quoi exactement?
So, that's, so she want to know more about what did you put in the recurrent cost, is it? Or, because you put in recurrent cost, you talk about health workers. So she want to know what was the cost you provide. Is it, for instance, if it's a salary or other things you provide for the health workers?
Okay, so let me try to explain. For the recurrent cost, we consider the personnel time cost. So that would be the surgeon's time cost for one patient's laparoscopic procedure, the surgeon's time cost for one patient's open procedure. We also consider the cost for the nurses. In fact, every medical personnel involved in every treatment. So for the surgery, we considered for the surgeons, the registrars, the anesthetists, the anesthetist registrar, the nursing sisters, the scrub nurses. You know, you understand what I mean. Then for the pharmaceuticals, we consider the medication. So the anesthesia, we also consider the medication. Sometimes when the patients come into clinics, they are given medication. So we also consider the cost of those medications. And then chemotherapy. The chemotherapeutic agents, we consider the cost of the agents. Then another component of the pharmaceuticals was the relevant consumables. So for example, the chemotherapy is administered with the lines, the drips, you know, the relevant consumables. And then the facility service charge was for some components of treatment that we couldn't work out their cost. So for example, would be how much does it cost for a patient to spend the night in Grutuscu in the post-surgical ward? Yes, and then how much does it cost to get a full blood count test done? How much does a CT scan cost? Stuff like that.
Thank you. Let's continue on your discussion together.
Voilà.
So you have
Merci
the floor.
beaucoup pour les questions. Donc, pour la première qui porte sur l'identification des indigents, je pense que dans la méthodologie, j'ai bien expliqué quels sont les documents qui ont été utilisés pour faire cette étude. Donc, le premier document, c'est l'enquête harmonisée des conditions de vie des ménages. Et je pense que beaucoup de pays réalisent cette enquête-là pour avoir les données sur la pauvreté et sur les indigents. Donc, nous l'avons utilisée et cette enquête est coordonnée par l'Agence nationale de la statistique et de la démographie. Nous avons aussi utilisé les résultats des comptes de la santé, donc pour pouvoir déterminer le niveau des paiements directs. Donc, c'est l'enquête qui nous a permis d'avoir l'identification des indigents. Donc, dans l'étude aussi, nous avons constaté que ce sont les maladies transmissibles qui tirent. Donc, les ménages dépensent plus dans les dépenses de maladies transmissibles. Donc, par rapport au calcul du taux de pauvreté, je pense que dans l'enquête harmonisée des ménages, nous avons la possibilité de sortir d'abord les dépenses de santé pour pouvoir calculer les autres catégories, les autres domaines qui permettent d'avoir la pauvreté. Donc, nous l'avons calculé sous deux formats. Un format avec les dépenses de santé, un autre format en laissant simplement les autres domaines qui intéressent la pauvreté. C'est comme ça que nous l'avons calculé avec l'appui vraiment des statisticiens de l'Agence nationale de la démographie et de la statistique. Merci.
Merci beaucoup. À vous, Dr. Amina.
Thank you very much for your question. I think So when I say equip or equip the primary healthcare system, what I mean is, for your country and our country, I think we are not too different. For our current policy, when it comes to care, you wouldn't find certain medication in chips, like certain medication for hypertension, diabetes, and mental health. So by virtue of that, they don't deliver that care. But per their design, they are supposed to do preventive activities. And as I mentioned in the introduction, they are supposed to do preventive activities for maternal health, communicable diseases. But I feel they could also include non-communicable disease without a direct policy shift. So they could actually include it. Okay, currently for our project, we are working on an intervention where we are trying to convince the government to include this essential medical list to the lowest level of the primary healthcare. But we are saying that before that, they engage in this preventive care. So they should at least, while they are doing preventive care for communicable disease, maternal health, they should include some components of NCD, which is hypertension, diabetes, and then mental health, while we are working from the policy angle. Okay, thank you.
Thank you very much. For this session, we can note that prevention is very important. Prevention is important to reduce disease, such as communicable disease or non-communicable disease like diabetes or cancer. Prevention is important to reduce the treatment cost, and prevention is important to reduce health expenditure. So thank you to all our speakers for your great presentation. Thank you for being here, and have a great
Good afternoon, ladies and gentlemen. Thank you very much for coming. I must apologize first first of all, my name is Chijioke Musu, and I'm going to be the moderator. The rapporteur is Dr. Chikezie Ifani, who will be taking notes and assisting in everything we are doing. Unfortunately, we don't have much time because I'm also mindful of the fact that you need to go for your lunch after this. And we have lost more than 30 minutes already because everything is accumulating. So as a result, we will really be very strict with time. We have 5 presentations. The general topic, as we all know, is innovations in African healthcare, decolonization, policy, and equity initiatives. Very important, very germane, especially as we are now talking about being self-sufficient in what we do, and also including the excluded in terms of healthcare access and provision. So I will introduce our speakers one by name, and then they will come and present when I call them one by one in this order. And please, we will reserve 10 minutes per presentation, please. So as a result, you quickly let us know what you are doing, what the topic is about, and maybe move straight into the substance, because we will be quite strict. The first presenter will be Dr. Geoffrey Waka, or Professor Geoffrey Waka. The topic is towards decolonizing medicine and healthcare, the place of African health and healing traditions. Can you just indicate by raising your hand so that we know? Thank you. The second presenter will be, as you said here, I think Dr. Chinyere Cecilia Okeke, priority setting for evidence-informed policy and the role of HTA during pandemic preparedness and response in Africa, and she'll be presenting a scoping review. The third, Dr. Lasumbi Makinde, it's a very long topic, title, but it's about cross-country learning collaboratives and how they enhance technical assistance to improve the infrastructure, to strengthen safe blood systems. Really, really an important topic here. And the fourth presentation will be by Dr. Hamid Keseli, Joint Human and Animal Health Campaigns in Chad. And the last but not the least is Dr. Togawa Shotaro, Political Economy Analysis of Multi-Stakeholder Collaboration in formulating a new UHC policy in Senegal. So without wasting time, much time, can I please invite the first presenter, Dr. Geoffrey Nwaka, to come and give his presentation. Thank you very much.
Thank you very much. Let me start by thanking the organizers for the opportunity to come here. As you can see, I don't attend conferences now to generate new ideas, but to learn from the younger generation. That's probably the best way to learn. My topic is about decolonization. My background is in history, and we have been teaching decolonization as that process of terminating colonial rule. But now we realize that there's more to decolonization than that the end of colonial rule, the end of colonial administration did not actually end colonialism. That we are now having to deal with Can we have the first? Okay. You can see I'm very old-fashioned with words and words and words. That's not the first slide, actually. That's. No. Yeah. What I say here is that there are two types of decolonization. Political decolonization, flag decolonization. But we ended that from about the mid-60s, or mid-50s to 90s. But what we have to contend now with is that we're having to deal with the institutions we inherited from colonial rule, which we didn't rethink. Our leaders who attained independence are behaving like gatekeepers of colonialism. They are gatekeepers of the colonial heritage. They haven't taken enough time to rethink the colonial legacy, whether it's in medicine or in my own area called urban studies, or in politics or in governance. So the problem is that the institutions of modernization in Africa are not operating properly because they have not been sufficiently decolonized. If you take, for instance, in my own area called urban history, we are now talking about alternative urbanism. I'm sorry, maybe I need a bit of water. We're talking about alternative urbanism, which means that the city planning we have, the cities we have now, are really not, thank you. So decolonizing medicine and healthcare is part of a larger picture of how to decolonize African institutions. Many people think that modernization in Africa has gone the wrong way. That modernization in Africa is like building a house from the roof down. Instead of building a house from the foundations up, we're building our attitude to modernity is completely misguided. We have people like Mamadou Dia of the World Bank, who thinks that Africans should try and reconcile modernity with indigenous institutions. That the way we operate our modern institutions is not operating. If you think about democracy, if you think about our healthcare, if you think about urban planning, these have not, I don't know why, I'm a little. So they're talking about indigenizing the forces of modernity, that modernity needs to be indigenized. So I'm part of the indigenous knowledge movement that says modernity should be indigenized. Medicine should be indigenized. The problem of the paper is how do you reconcile modern medicine with traditional medicine? Decolonization is not a rejection of modernity or even Western modernity. but rather a challenge of rational choices between development thinking and legacies of colonialism. So when we say decolonizing, we're not saying reject modernization, reject modernity, or even Western modernity. The Asiatics, those in Asia, have done a lot better than. I'm a little worried, I don't know why. Sorry. My apologies, I'm fine. No, I'm fine. I am saying that the Asiatics have done a lot better than Africans in modernizing. They have been more selective in their approach to modernity. In Africa, we have gone overboard with modernity as was inherited by the colonial government. And I am saying that healthcare should not assume that Africa is a tabula rasa. There was no healing tradition. Sorry, I'll sit down. I'm sorry, I apologize. I'm saying very briefly that modernity should be African modernity. That we have decolonized, we have acquired independence. But that does not mean we have decolonized our institutions. And because of that, the institutions are not working well. Whether it is practice of democracy, whether it is the practice of medicine, whether it's the practice, these are not working well because we have not domesticated them. We have not indigenized them. Marshall Sahlin, one of the people I talked about here, says that we need to indigenize the forces of global modernity, and that the only response to globalization is the response we generate from the local level. That's the only way we can. Mamadou Dia of the World Bank thinks that the conflict in Africa is between the institutions we have inherited from colonial rule and the ones we have. How do we reconcile? That's what they call institutional reconciliation. How do we reconcile the institutions of modernity and the institutions we inherited? So it's the same thing in healthcare. We are not romanticizing African traditional medicine. All I'm saying in the paper is that Africa had a way of healing people. Africa has health and healing traditions. These should not be romanticized because they have their own problem. The entry into traditional medicine is chaotic. Almost everybody is centering now. Even though there are traditional herbalists who had skills in treating people, now everybody, the diagnosis is not, there's one medicine they call Boborishe. It's supposed to cure everything from headache to venereal disease. So there's a problem with traditional medicine. On the other hand, modern medicine, maybe I should now go. Sorry. Well, what I said is that traditional medicine has its own defects. It has its own merits, but also it has its own defects. The same way, traditional medicine or modern medicine, even though it has many claims, I mean, certainly it has obvious merits, but it's not perfect. And I mean, it doesn't serve, it's not accessible, it's not affordable to many people. It makes wide claims. And even in modern medicine, now you have quacks. There are all sorts of people who sell medicine without prescription. There are people who treat, just like in traditional medicine, there's a woman in my family who went to a traditional healer. He gave her the right traditional medicine, but also gave her a few antibiotics to administer. So there's this indiscriminate blend of traditional and modern medicine, and this is this is the real crux of my problem. How do we reconcile the traditional and modern the same way I talked in my opening remarks? How do we reconcile? How do we actually promote African modernity that takes cognizance of the African roots of modernity, but still, you know, it's modern? As I said, the Asiatics are a little more advanced in this. Asians are developed, they are modern, but their modernity is not like African modernity. If you take the practice of democracy in Africa, it's chaotic because we say traditional institutions are not compatible with modern democracy. So the main challenge is in practice of medicine, in the practice of medicine, how do we recognize that Africans had medicinal practices, they had a practice. How do we now reconcile traditional and modern medicine without this indiscriminate mixture of, if you come to modern medicine, they are making wild claims. I remember during COVID, I mean, all sorts of prescriptions were made about controlling and injecting vaccines. With hindsight, we find that, oh, sorry. Well, it's not a very good, but what I'm saying is that during COVID, for instance, we got the model of our COVID control from China and from Europe, and we did not relate it properly to the local African situation. So in adopting the prescriptions of modernity, how do we ensure the African context in which these developments take place? Well, my time is I apologize for the mix-up, but simply I'm saying that we have gone overboard in Africa in our quest for modernity. The modernity that we are pursuing has not been properly decolonized. How do we decolonize African modernity? Whether it is in the judicial system, we still see our judges wearing wig in courts. We still see the practice of democracy is now alien completely. Local institutions are not taken into account. In the practice of medicine, doctors hold traditional healers in contempt. How do we recognize that in the practice, both of modern medicine and traditional medicine, there's merit and there's weakness? How do we use the weaknesses of one section to offset the advantages of the other? How do we promote this institutional reconciliation, which is the real message of my presentation? I apologize again for the mix-up.
Thank you very much, sir. Really very interesting and thought-provoking presentation, because the issue of traditional medicine is important, but as you did mention quite sagely, while it's important, there needs to be standards. It should not be it should not be if anybody comes up and decides to give whatever they have and call it traditional medicine. There needs to be an infusion of standards, need to properly reconcile modern and traditional medicines for effectiveness. Thank you very much. So I just got to learn that two of the presenters have not submitted their presentations. Can I ask if Chinyere Okeke is here? No. Can I ask if Hamid Keseli is here? No. So we actually have 3 presentations instead of 5. So while in the interest of fairness, I will still stick to the 10 minutes, but then we'll have more time possibly for the panel discussion. So may I call to the podium, Chinyere Okeke is not here. May I call to the podium Olasumbo Makinde to come and speak to us on learning collaboratives for strengthening blood systems. Thank you. So please.
All right, that's fine. Thank you. this me? Okay. I need to be sure. Okay, fine. Good morning, good afternoon, everyone. So really, I just want to highlight some of our learnings from the cross-country learning collaborative, all in the bid to enhance the blood systems across 3 countries, that is Liberia, Malawi, and Rwanda. Okay, for this presentation, I'll run through a brief background, methods, results, and conclusion. Okay. When you talk about blood, you understand the importance of ensuring that there's access to timely availability of blood. But for us, we looked at it in the lens of maternal care. PPH remains the leading cause of maternal mortality globally. For you to manage properly PPH, that is postpartum hemorrhage, you need to ensure that there's timely availability of blood. However, in low and middle income countries, this remains a problem. Hence the reason why this was started. For so many national blood systems across low middle income countries, they've been able to address some of these issues using funding, both within from the government and also international funding. But I'm sure everybody in this room understands that there's been dwindling funding when it comes to support for countries. Hence the need for countries to begin to share learnings across board and collaborate together to address some of these major issues when it comes to delivery of care across board. Our focus has been on, okay. Our focus is really around ensuring that countries can learn from one another using cross-country learning and be able to improve their individual countries' blood system services. What did we first do? We wanted to understand what were the gaps when it comes to the blood systems across these 3 countries. From what you can see here, so I'm trying to get, okay. All right, I'm trying to use the pointer to see the red lights. Okay, it's not there. Yeah, so from what you can see there, you can see how these 3 countries differs when it comes to the structures they have available. We looked at it across these 3 major areas, that is regulation and policy. At the extreme left there, you have Liberia, and you can see it's almost all red. Actually, it's all red. What we discovered was that they didn't have regulation, they didn't have adequate policies in place. When it came to immovigilance and quality assurance, they were also lacking. Compare Liberia to what we had in Malawi, they seem to have improved considerably compared to what we saw in Liberia. However, when it came to funding and staffing, it was a major problem. In Rwanda, yes, we saw better systems there, a more mature system, but when it came to immovigilance and quality assurance, it remained a problem. And so looking at these 3 areas, we saw that these 3 countries were a good fit to learn from one another and to improve their systems. In addition to the cross-country learning, there were also support that were provided for these countries, and that's what I just highlighted. Sorry, next slide. Sorry. All right. And that's what we highlighted here. I should mention that this project was being supported by the USAID, and it was under the Accelerator project across a couple of countries in Africa. And for this bit of the work, there was support around establishing technical working groups in each of these countries to help them institutionalize their safe blood systems, ensure they had systems in place, ensure they had the right guidelines and SOPs, and even around immovigilance, and ensure standardization when it comes to blood drives in each of these countries. But for our conversation today, we'll only be looking at the cross-country learning bit of the work. Okay. The aim of what I'm trying to share with you were some of the things we were able to do from cross-country learning, how they were able to improve and complement the forms of traditional, to complement the traditional technical support being provided, and also for them to be able to strengthen their system for continuous change. How did we go about this? First, we did an assessment to even understand what were the system, what were the challenges. Like I shared earlier on, we went further on to understand when you even talk about immovigilance, what exactly about immovigilance, what's the problem? So we did a self-assessment. Each of the countries did a self-assessment to understand what the problem was in their countries. Following that, we then did and what's it called, a qualitative assessment, we spoke to key informants within each of the three countries to understand how is this affecting your ability to deliver quality care when it comes to availability of blood and its blood samples. From all of these conversations, we're able to get in a little deeper insight into the problem and how to support them. Based on all of these that we're able to gather, we then went on to validate all we got from each of the people we spoke to. We had a learning forum where everybody was able to look through some of the things we gathered, and they were able to come up with an agenda of what they wanted the cross-country learning to focus on. Based on these topics were actually highlighted, and that was what became the basis on which the support was provided. And so the support itself for the cross-country learning was a mix. We used both virtual and in-person learning. For the topics that across the three countries, based on their challenges and the similarities of the challenges they had, the countries prioritized blood donor mobilization and retention, immovigilance. They also prioritize the use of performance management to make decisions when it comes to where blood should be made available and how these blood samples should be made available. Of course, for all of these things, we're able to learn within Africa to get experts within Africa. We got experts from the Zimbabwe Blood Supply, from Lagos, from Namibia, and also from the Coalition of Blood Services for Africa. All of this enriched the conversation and the cross-cultural learning across these three countries. Finally, like I said earlier on, it wasn't just the cross-country learning that was the support provided, but what we also did was to leverage what was being done from the technical assistance being provided in each of the countries and ensure everything they were learning from the cross-country learning was integrated into the TA that was provided in the countries. Looking through all the sessions that we had, both the virtual and the in-person sessions, these were just a snapshot of what we did. For each of the five areas that the cross-country learning centered on around the blood donor mobilization, we got the learning outcomes which are around. Let me start with this first one. For the first session, the focus was on them learning what was being done in Malawi. We saw that Malawi had a school system for for blood donor mobilization. They were able to teach the other two countries to explore the use of the school system as a way of ensuring blood was made available in the country. Moving on to the next session was around immovigilance. We're able to learn from Lagos. Lagos has a viable system when it comes to immovigilance. They were able to teach the countries on what they were doing, best practices, and how they were able to adopt this into the three countries. Also around the use of activating hospital transfusion committee. If I recall, Malawi and Rwanda said they had this in place, but they were not being used consistently. From the cross-country learning, they were able to learn the importance of having these HCCs available and how they were able to use it to ensure a good system within each of these countries. All in all, we're able to learn from one another, get input from the experts to improve the systems in each of these three countries. In addition to learning, the three countries were able to come up with knowledge products with our support on how to do things better. One of the major knowledge products that was developed was a how-to guide when it comes to blood donor mobilization in the country. What is the standard? What does evidence show? And what can we adopt in each of the countries? Also, we had a toolkit around hospital transfusion committees. How do you set them up? How do you ensure they meet regularly? And how do you get your desired outcome? Specifically around the last two sessions, which were the in-person sessions, we saw tremendous feedback from all of the participants. Most of the participants were very pleased with the amount of work that went into bringing them together to learn from one another. I'll read the last one that says, across board, learning sessions were very valuable. And the fact that we had an in-person session was truly one of a kind experience. From the graph you have there, you can see how strongly most of the participants agreed when it comes to the feedback they were able to get from the learning session. I'll just look at the first one. It says, I am equipped with sufficient knowledge to lead my team to improve the blood system in my country. Looking at the last one, it says, the various speakers at the learning sessions were very engaging. So it wasn't just about the expert providing information, but they were able to give them what they do, and they were able to work together to come up with the best practices across the different countries. This just, okay. This is just a snapshot of some of the activities that I went through. For the in-person session, it was actually done in Namibia, and they were able to see the extensive work the Namibia blood system, blood transfusion services were doing. We're able to look through the services and the equipment they had, and how they were able to utilize the limited resources they had in country to actually improve the blood system in their country. All in all, what did we see? It isn't enough to just provide TA, but the fact that there was opportunity for them to collaborate with other countries, to learn from other countries, was a big push in ensuring success in each of these three countries. Incorporating customer care at blood donation sites was discovered to be an improvement in ensuring recurrent donors across all the countries. Beg your pardon. Incorporating the blood management system was also one that helped the countries, especially in Malawi, to improve the blood system in their country. Yes, funding is dwindling, but each of the countries were able to come up with an investment case to ensure they had continuous funding to improve their blood system in their countries. By utilizing cross-country learning and technical assistance as a complementary to each other, we're able to further strengthen and ensure a more efficient and sustainable improvement in the blood system in each of these countries. What were our key lessons? Stakeholder buy-in was very crucial for the success we saw. Yes, we met the individuals at each of the departments, but the fact that we had the buy-in of the leadership, we're able to achieve our desired outcome. Having a platform where engages or encourages collaboration was also an important factor that we saw resulted in the success. Ensuring that all of the things you're doing, you ensure you have knowledge products that can help participants to continue to refer to promote sustainability was another important thing we learned from the whole process. Thank you.
Thank you so much. So for me, this is interesting given that, and I think these common themes are coming out, like I was in a session yesterday on about how the continent can become self-sufficient in producing its own vaccines. The key lesson coming out recurring across all the presentations was about the need to come together as a continent to increase cross-national collaborations. And this is really this call in action. I'm really excited about this and really want to know how this will play along, especially also if you can incorporate other countries going forward. Thank you very much, really important. So last but not the least, we will invite our last speaker, Togawa Shotaro, on talking about the political economy analysis of multi-stakeholder collaboration in formulating a new UHC policy in Senegal. Thank you.
So thank you, moderator, for the introduction. So my name is Shotaro Togawa. I'm working for JICA, Japan International Cooperation Agency, and I was based in Senegal from 2019 to 2022, almost for more than 3 years, as a health team leader of the JICA Senegal office. And now I'm back in the headquarters in Tokyo, but I still continue my research on health financing in Senegal as a doctoral candidate at the London School of Hygiene and Tropical Medicine. So today I would like to present part of my research about the political economy analysis of the multi-stakeholder collaboration in formulating a new UHD policy in Senegal. So, as you all know, health financing reform is inherently complex and political, and which also requires the collaboration of among diverse stakeholders with often conflicting interests. And in this context, the political economy analysis is a useful tool to really implement the reform and policy making in the local context of each country. Even WHO published how-to guide last year. And in Senegal, the government has embarked on the evaluation of its universal health insurance program and subsequent formulation of a new policy called PSD-CMU, CMU, since 2019. So I looked at this process and conducted 31 key informant interviews and collected related documents last summer to really understand the collaboration process in the policy making and elicit some practical recommendations to really implement this policy reform. So this is the analytical framework I used. I combined two frameworks called, one is political economy framework. I think this is a very famous framework which categorizes 6 groups of the stakeholders typically involved in health financing reform: the interest group and bureaucratic group and budget politics and leadership politics and beneficiary politics and external actor politics. And this framework enables us to exhaustively capture all the stakeholders involved in the health financing reform. And the second framework I used is called Integrated Framework for Collaborative Governance. So this framework looks at how the stakeholders are collaborated and interacted in the process of policy making and implementation from the 3 dimensions of the collaborations. The one is called principled engagement, and the second is called shared motivation, and the third is called joint capacity. I will come back later about the detail of each dimension. So this is the funding flows in the financial protection schemes in Senegal. I know this is very complex and complicated, but I will not go into the detail. But here at the center, we have the service providers, health facilities, and they, in terms of public health facilities, they receive substantial resources from the Central Minister of Health, but they also have several different revenues of resources from the different financial protection schemes. So in the left, we have the formal sector populations. They were covered by some different financial protection schemes since 1970s. But they constitute only 10 or 20% of the total population. So the government of Senegal, they started the new program called the CMU program in 2013 to cover the rest of the population, which is the informal sector. And this program consists of mainly 2 components. The one is the free healthcare initiative, which is targeting some subpopulations and some specific services to be covered for free. And the other is the community-based health insurance called community mutual health organizations. So with these 2 schemes, managed by the national agency now it's called Senegalese Agency of UHC, which is supervised by the Ministry of Family and Solidarity. And this national agency was originally placed under the Ministry of Health, but in 2019, it was transferred to another ministry based on the principle of the provider-purchaser split. So to optimize these complicated health financing schemes, they started the health financing reform and started the elaboration of the new policy. So this is who got involved in this process. So there is a steering committee and technical committee in charge of elaborating the new policy. So I just categorized the members of these committees by the political economy framework. So I won't, again, there are so many stakeholders, so I won't go into the detail. But in this process, the Ministry of Family and Solidarity and its national agency of UHC were playing the crucial role to coordinate with these stakeholders. So let's look at how these stakeholders actually interacted and collaborated in the process. So first dimension of collaboration is called principled engagements. This is about how different stakeholders interacted and based on what kind of rules. So to make it easy, I divided my findings into the two, the good practice and the things to be improved. So there are of course some good practices. So the first is there was a clear ministerial order by the Ministry of Family and Solidarity, which defined the procedures and the members of the steering and technical committees which are in charge of elaborating the new policy. So based on this ministerial order, the National Agency of UHC was able to mobilize the financial resources and recruited the competent local consultant to draft this policy. And these consultants did a fairly good job, and they undertook the discussion with a wide range of stakeholders who were not necessarily involved in the steering technical committees. And also, development partners provided some crucial technical inputs with the local expertise. By the way, I'm not talking about my organization, but the other organization, they really mobilized the resource person who knows the local context in Senegal to support the development of this new policy. But there are some things to be improved. So this ministerial order does not really specify the individuals or the detailed affiliations of the committee members. It just says this ministry or this organization should be included in the committee. So there was some confusion who should represent from which organizations in this committee. And also there was some weak representation from the beneficiaries group of each different financial protection schemes. Also the universities and private sector, they were underrepresented in these committees. And when we look at the actual discussion, the meeting of the committees, actual participation was very limited to the several organizations, which are the National Agency of the UHC and its supervising ministry and some development partners. And the other organizations, stakeholders, the members are not substantially engaged in the process. And they told me they should have been more involved from the earlier stages. And why they were not involved? There are several reasons, but one of the reasons is that all the meetings, committee meetings were conducted online to allow for the flexible participations. But actually, when I look at the invitation, it was not sent to the relevant members of the committees. So if you don't receive the invitation with the online meeting link, you cannot participate. So this is just one of the reasons, but it was the kind of obstacles to really promote the participation in these committee meetings and the process of the policy making. And the second dimension of collaboration is called shared motivation. This is about mutual trust or mutual understanding among the different stakeholders in the collaboration. So the good practice was, there was a good understanding and strong commitment from those who were able to participate. So it is mainly the members of the National Agency of UHC and its supervising ministry and development partners. And also there was they tried their best to share the information and the result of each meeting by sharing the note of information and minutes of meeting to the other stakeholders which didn't participate in the meetings. But on the other hand, there are some things to be improved. So there are some distrust with the community mutual health organizations and also the service providers to this UHC program. The main reason is the reimbursement rate was really low. Due to the financial deficits, the government was not able to reimburse the subsidies to these organizations. But there are some more complex and complicated political issues, especially with the community mutual health organizations. And this fact really was undermining the beneficiaries' trust and participation in the program itself. And also there was lack of understanding among the stakeholders in this UHC program, and also the role of the National UHC Agency as a coordinator of all the financial protection schemes. And also there was some misunderstanding or not clear understanding of the share of the responsibilities across all these different stakeholders and ministries. And there are also, some informant told me there seems to be some lack of coordination or even some tensions between the Ministry of Health and National Agency of UHC. As I said, the agency was transferred from Ministry of Health to another ministry in 2019. And since then, some of informants told me there seems to be some collaboration and misunderstanding. And this is illustrates by the fact that the Ministry of Health, they started to develop their own health financing policy in parallel at the same time with this Senegalese UHC agencies policy making. So the last dimension of collaboration is called capacity for joint action. So this is as a result of collaboration, what kind of capacity was developed for the joint action? So good practice was the new policy was actually drafted based on the exhaustive document review and qualitative study with the local expertise. So when you look at the contents of this policy itself, it says really good things. So it's beautifully drafted and elaborated. And the process strengthens the network and leads to the continued collaboration among those who were able to participate. But on the other hand, the process did not really materialize the better understanding and trustful relationship with a wider range of stakeholders, which is really crucial to implement this complicated policy. And this implementation of new policy may require the strong interministerial coordination mechanism, which could go beyond the mandate of the National Agency of CMU, which is under one Ministry of the Family and Solidarity. And last but not least, more importantly, the financial feasibility was not really examined with the Ministry of Finance in this policy making. So this is another issue of this policy making. So my time is up. So my recommendation, the conclusion and recommendation is the policy itself was beautifully drafted, but there are some room for improving the interministerial coordination in harmonizing related policies. And also the distrust and tension among some stakeholders should be addressed to successfully implement this policy. So thank you very much.
Thank you very much, Togawa. Also interesting presentation, because it's always a challenge. I mean, universal health coverage is the way to go. However, we in any country decides to go for it. But the important thing is that people receive the quality health care that they deserve, that they need at each point in time. And this also even links beautifully with today's plenary about the experience of Rwanda with regards to covering almost the entire population, at the very least more than 90% of the population. And I believe that there will be lessons for Senegal from Rwanda, especially in the context of limited resources. How do you innovate? Okay, so may I please call three presenters to come to, is any of the other presenters now around? We had Kesali and also Chinyere. Has any of them now come in? Because we had 5 presenters, but only 3 were here at the beginning. Okay, if not, please, can the 3 presenters please come up, and then so that we can open the floor for the panel discussion. Thank you. Can I please ask that colleagues raise their hands if you have any questions for any of them? And yes, I've seen one. Any other? Okay, please, can you go? Yeah, this is the first hand I saw. She's coming with the mic.
Thank you very much. My name is Fakwanja Dwyer from the Ministry of Health. So I think it was a very interesting presentations. I have a question towards two of the presentations. The first one on the MPTS, the blood transfusion services. And I just wondered because it was based on a self-assessment, and I know you indicated that the validation was done through the co-learning event that you had with all the countries MPTS, but I still wonder, um, could there have been, or was there any other measures to ensure that the results coming out are not biased, given that they are self-reporting? So I think that's my question on that. And then the second question is towards the last presentation. And I thought the diagram you presented showing all the interplays in terms of the organizations working in this space. And I wonder if this process of aligning also addressed the issue of having multiple pools of funding. And then I think my other question was, I think it's a question that most of Ministry of Health struggle with, is the split, the purchaser provider split. And I see that they've handled it well by moving it to a different ministry. But I wonder, maybe outside of the scope of the presentation, but I also wonder how whether the ministry that was chosen had the requisite expertise in terms of handling this, and how that was addressed, if it was addressed. So that is my questions. Thank you.
Thank you for the very insightful presentations. My name is Yewande Ogundeji from Health Strategy and Delivery Foundation in Nigeria. I have, I would say, a comment and a question. So a comment to the first presenter on the decolonization of health and traditional medicine in particular. I do know that in Ghana, they've gone a bit ahead of many other African countries. So there's like a whole system for traditional healers, there are associations, there's research that has advanced quite, that has progressed quite well. I mean, I'm not in Ghana, but I do follow up a little bit on that. So that might be interesting to see, you know, where they're at with that and how other African countries can learn from what they're doing. But I do know that they're quite advanced in, you know, trying to integrate and standardize traditional medicine. And then my question is to the last presenter. I mean, my organization, we support multiple health insurance schemes and just health system strengthening in general. And the issue of political economy is like one of the rate limiting steps sometimes in moving policy into action. As you said, in Senegal, you know, beautiful policy, and we see that a lot in my country, you know, some of the policies are fantastic, but in terms of implementation, it's just, you know, it's just stagnant. And we tend to look into political economy a lot to see how we can influence that decision-making space. So in the case of Senegal, because we also do some work in Senegal, I'm wondering, what would you say was the biggest or largest enabler when it comes to, you know, moving that policy a little bit or just advancing it? What would you say from your research, from your findings, into looking into the political economy? What would you say was the largest enabler? Thank you.
Thank you to all the presenters, quite insightful presentations. Starting with the decolonization. It's a very interesting area of research, but I just noted two or three things that you said. One is that our politicians are the gatekeepers of colonialism. Because sometimes you wonder, you look at what is happening in Asia, and all their medicines are actually on our shelves. They are so-called traditional medicines. They're available. China, same thing. But that doesn't stop the other medicines also to be there. But we followed on from the colonial period where traditional medicine was kind of looked down upon. We passed these legislations like the Witchcraft Act. Of course, the churches were very strongly advocating against traditional medicine. If you are seen there, then you are an atheist or something like that. But on the ground, we know that 80% of our population, that is their first entry into the healthcare system. They try it before they go elsewhere. And yet we pretend that there is nothing we can do. Well, some countries are trying, but I think we need to advocate a little more so that we free ourselves. Actually, even our colleague there from Japan, they have a very strong traditional medicine system. They are using it. There's nothing wrong with it. And after all, even in modern scientific medicine, almost 80% of healing is the brain. You believe that you'll be healed, and you actually get healed. This is scientific. So I don't know why we want to keep pretending. Now, Senegal is a pioneer of community-based health financing. I actually worked for an organization where we used to take people from this part of the world, from East Africa, to go and see what Senegal was doing. I am surprised that many years later, we seem to be going in reverse gear, and we have forgotten all those experiences. And yes, we are writing beautiful documents, but which at times are difficult to implement because of the way we do them. So how can you develop a policy without the involvement of finance, of the Ministry of Finance? In many countries, the moment you begin talking about a new policy, you have to seek a clearance from the Ministry of Finance that there will be resources. You have to actually justify that your new policy can be implemented because of the financial implications. So you get a certificate of clearance of financial implications before you go further. So I'm surprised a bit that you are saying Minister of Finance wasn't on board. Of course, there are many issues with this split, the purchase and that purchase and provider split. I think it's something that many countries have struggled with, right from the UK, to which many of us look forward. And they don't seem to have gotten answers. But now, we also seem to be spending a lot of time on those splits. So you create a Ministry of Family and Solidarity, so that it becomes the purchaser and then the Minister of Health is the provider, but actually the Minister of Health is not a provider itself because it's at a different level. So, you know, you begin creating agencies, and I think we need to style up. Thank you.
Thank you for the question. Yes, like I said, for the qualitative assessment, to ascertain the topics to cover, we interviewed an average of 15 healthcare workers, if I would use that. But we looked at it from the bottom to the top. So people working in the lab, people working at the district level or the LGA, whatever the situation was, and then to the senior leadership, who interviewed all of them. And then for the validation, what we did was we then spoke to the leaders. This is what everybody's saying. What do you think is the most important? And yes, like you said, there was a lot of bias. But like I said in conclusion, it was important for us to have the leadership's buy-in. So if the bias was from the leadership, we're fine with it because it meant they were going to support the agenda and they were able to, and from the results we saw that because there were areas that they felt were the most important, they were able to support to ensure the successes we saw. But I think for us at the end of the day was, if you understand how to do this cross-country collaboration to address these common areas, then the same can be applied to other areas that they think are also important in the future. So that was really the approach for us. Thank you.
Thank you very much for the comments, and apologies again for the mix-up in my presentation. Yes, part of the problem is that the early nationalists, were antagonistic to tradition. Some of those who fought for independence, they thought that tradition was something retrograde. They went overboard with modernity, Western modernity, and forgot their own institutions and so on. And that prejudice has continued. That's why I said they act as gatekeepers of colonialism. They assume that the end of colonial rule ended colonial, and that is the end. We have a stronger battle to fight now to decolonize our institutions, whether it's in health or in urban planning or in the judicial reform and so on. So we need to decolonize our own institutions and make them really African. Asians are doing much better, as I said. They are modernizing, but on their own terms. African modernity, we should indigenize the forces of modernity. Modernity doesn't mean how things are done in the UK or in the United States. So I appreciate the comment. Ghana is certainly taking the lead. I was in Ghana in December for something else, but I was interested in how far they have gone with modernizing their indigenous institutions. I met a lady there who trained, she did a master's in China on traditional medicine, how to adapt and so on. And she's leading one of the institutions in Ghana that there's something in Nigeria. I know people like Morrissey who have established institutions where they are trying to prepare African pharmacopoeia, the directory of medicinal plants and so on. But as you said, Ghana is far ahead of Nigeria in this regard. We have a long way to go, not only in medicine, but in various other fields, in the judicial system. Just like COVID, I'll end by, during COVID, I mean, we got the model from China and somewhere, and we came to the cities and we said, no movement, hand washing and so on. Many people in the informal sector, they don't have water, they don't have refrigerators to, so many people were actually killed by policemen, harassment of, or by so in modernizing, we must take the local context into consideration. That's the only point I was making. Thank you.
Thank you. I've been informed multiple times that we've overrun time. Please, can you be as brief as possible? Thank you.
Thank you very much for the questions. So the first question about if they are reducing the funding pools, and the answer is yes. They are ultimately trying to have one pooling in the country, but it's the way too far to do it immediately. So they had planning some steps towards this policy. And they are also trying to harmonize the benefit package and also premium contributions, the amount, which are quite different currently according to the different schemes. And the provider purchaser splits, it's the difficult thing. Many informants told me it's right in principle, but it was maybe too early in Senegal. It was kind of suddenly introduced by the initiative of the president, and many of them informants told me they really still need to work with the Ministry of Health. So maybe it was too sudden. So, but they are still doing their best. And also about the biggest enablers, it's the difficult question. I would like to know that. But I think talking about pioneers or the CBHI, community-based health insurance, this and also the formal sectors were covered by the different schemes which has the colonial, the history of the schemes. They are covered since 1970s, and the CBHI, they have their long history. And so they have each scheme has their own history and tradition, so it's really difficult for them to merge into the one pooling or one mechanism. So that is kind of a hindrance for the optimization of the system, I suppose. So what I recommended was have the stronger interministerial coordination. So the Prime Minister office can convocate all the other ministries. So this could be one enabler. And I also present this research is kind of action research. So I work together with the UH agency in Senegal and present this result with all the other stakeholders. So by little, with these small steps, I hope that they have the better system and to achieve universal health coverage. Thank you very much.
Thank you very much to the presenters. Thank you to the audience. Again, I mean, very interesting and important lessons. Traditional medicine about also cross-country collaboration and as well as improving universal health care design and delivery. Thank you very much. Sorry once again that we have significantly overshot our time. Lunch is still, this is time for lunch, and lunch is still where we normally have lunch. Thank you very much, and do have the rest of the day.